Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thanks for listening to Behind the Knife. Kevin here. For all of those who chose to pursue the pinnacle of surgery, vascular surgery of course, we have a course for you. Our vascular surgery oral ward review has 72 audio scenarios from carotid stump syndrome to a patient with a AAA and a horseshoe kidney. Everything you need to be ready for your vascular rotations and oral boards. As an added bonus, your course purchase now comes with access to our new oral board simulator. It is a total game changer that lets you run through voice-prompted cases and receive instant scoring on your performance. Access all of it via the app for on-the-go use. Enjoy the episode and dominate the day.
Hey, welcome to Behind the Knife, Clinical Challenges in Vascular Surgery. I'm Andrew Huang from the University of Michigan. I have with me here Frank Davis, Robert Beaulieu, and Luciano Delbono. And today we're addressing asymptomatic carotid artery stenosis. So for decades, a tight carotid stenosis felt like a ticking time bomb, like a plaque that's waiting to throw an embolus and cause a stroke. For years, physicians were taught that severe narrowing meant surgery, with numerous trials such as the ACAS trial, the ACST-1, demonstrating the benefits of intervention. However, medicine has changed. In the decades since, with numerous new medications such as statins, antiplatelets, different blood control agents, and PCSK9, as well as GLP-1 therapies, have quietly slashed stroke risk, and now even newer data from the CREST-2 trials has introduced new questions on how to care for asymptomatic disease. Therefore, if modern therapy works better than ever, who actually benefits from an intervention and who needs an intervention? And today we're going to go over the evidence, the controversies, and the approach to a patient who may feel fine but has a high-grade stenosis in clinic. So the first discussion question is, why does the management of asymptomatic carotid stenosis remain so controversial?
Yeah, thanks, Andrew. So I'll take this one. So the old landscape with some of the older RCTs showed that CEA clearly reduced stroke risk versus medical therapy alone in both asymptomatic and symptomatic stenosis patients. Some of the older estimates using the ACAS, the NACIT, and the ACST demonstrated a 2% stroke per year in high-grade asymptomatic carotid disease with an absolute risk reduction of about 5%, with CEA plus optimal medical therapy versus optical medical therapy alone, with about a 50% stroke prevented at 5 years per 1,000 CEAs. This led to the SVS and AHA guideline recommendations for treating high-grade asymptomatic carotid stenosis in those patients. However, CREST-2 is a trial that has come out recently that has thrown some controversy in these statements, but we'll kind of go over those at a later time. So, Bobby, do you want to kind of lead us into some of the optical medical management and how that sort of changed the landscape?
Yeah, totally. Because I think understanding the medical management realm of this really helps explain a lot of the controversy. What we were originally seeing is that when most of these trials came out that touted the benefit of asymptomatic carotid interventions, it was really aspirin. So antiplatelet therapy with aspirin was the mainstay of our treatment regimen. But this has really changed recently, and the addition of some of these newer agents, including some of the follow-up trials which have demonstrated low stroke risk amongst the cardiovascular outcomes used to get these patients or these medications approved, really has brought into question whether or not these are better than our previous medical treatment strategies, and therefore throw into doubt some of the comparisons with some of our intervention arms before. So let's just talk about sort of the standard of care medical therapy. As we've talked about, antiplatelet therapy is one of the mainstays of reducing the risk of TIA and stroke in patients with asymptomatic carotid disease. And asymptomatic carotid disease is typically managed with 81 milligrams of aspirin daily. Some of this is based on the Antithrombotic Trialist Collaborative, which showed the combined cardiovascular risk reduction was the highest amongst patients who are on aspirin 81 compared to any other dose. So you don't really need to have these patients on 325 of aspirin. Some have wondered, well, what about the addition of clopidogrel? So you're on dual antiplatelet therapy with aspirin and clopidogrel. And for a while, it was thought that maybe adding these to the very highest risk of patients might be the way to go. So those patients with 75% and above, but not occluded, might benefit the most. And really the Charisma trial, which looked at the use of dual antiplatelet therapy for a number of vascular indications, didn't really show much of a benefit. There's probably one group that benefits from the dual antiplatelet therapy the most, and we're going to talk about this outside of the intervention arm, and that's those that have had a recent TIA based on the CHANCE trial. So in that trial, they started patients on clopidogrel plus aspirin within 24 hours of their minor symptoms and found a significantly reduced stroke risk at 90 days. So that's not really within the purview of our discussion of asymptomatic disease, but it's probably one of those things that's just really good to know. There are other elements of appropriate medical therapy, and that includes being on a statin, and really high intensity statin. The AHA and SVS define high intensity statin pretty strictly. So that's patients who are younger than 75. That's either atorvastatin or rosuvastatin. So that's Lipitor, Crestor at 80 milligrams or 40 milligrams respectively. If they're older than 75, you can drop that dose down to 40 milligrams of atorvastatin and 20 milligrams of rosuvastatin, and that's considered high intensity therapy. It's also aggressive blood pressure management, and I think that that's probably a staple of therapy for most of our patients, regardless of their carotid status. But really, we're talking blood pressure in the 130 to 135 range and below. Seems to have the best risk reduction. You want to target in glucose, a target A1C of less than 7%, and the GLP-1s have really moved the needle on being able to accomplish that with either injectable or oral agents pretty well, despite that being a really hard target for a lot of people for a while. And then there's the sort of standard things that you should counsel all your patients about, including smoking cessation, exercise, and weight loss strategies. And I think this really is a nice segue into some of those newer agents, because the weight loss and the diabetic control are really well accomplished with the GLP-1 agonist now. And what we found is that those have been demonstrated to have an overall cardiovascular risk reduction, and hasn't been specifically studied in carotid disease, but we have seen in patients where the outcome is a combined one that includes stroke, that it seems to be a pretty low risk. So there's a lot of patients who have gone on that and noticed the benefit, though I wouldn't say that's standard of care for doing that for asymptomatic high-grade carotid disease. PCSK9 inhibitors, you're thinking like the evolocumab and Pathan stuff, those ones are pretty widely accepted in clinic now. And what we've seen is those reduce your LDL by typically 30 points on average. So really helpful for not only those recalcitrant patients who are on statin but can't get below that 70 mark that we shoot for asymptomatic high-grade disease, but so not only those patients, but also ones who just can't tolerate statins. They seem to do really well with these PCSK9 inhibitors. And there's a few RCTs that have looked not specifically just at carotid disease, including like the Odyssey trial and the Fourier trial, and shown that they've reduced cardiovascular events as well. So, I think that the medical therapy really has improved, and this has probably been the biggest element that's led medical physicians to say, hey, should we be intervening on this at all? Because I'm seeing such an improvement with the addition of these modern agents. And so I think before we can sort of say yay or nay, we need to get into a better understanding of what interventions we're even talking about.
Yeah, thanks, Bobby. And I think that's a really good summary of what is considered optimal and best practice medical management in the current day and era for patients with asymptomatic carotid disease. And indeed, patients who come into your surgery clinic, it's really important that the first thing you have to do is optimize their medical therapy. But even after optimizing their medical therapy, I think let's get a good understanding of the different surgical options for patients with asymptomatic carotid disease. Now, Andrew, I know in the past, there's been a number of trials that looked at asymptomatic carotid artery disease and looked at surgical therapy versus optimal medical management. Do you mind kind of touch base upon what those trials are and what they showed?
Yeah. So one of the first trials for this was the ACAS trial, and this was the one performed in North America. This went from 1987 to 1994, so a long time ago, but enrolled 1,600 patients who were asymptomatic with a greater than 60% stenosis. The endpoint for this study was a 5-year stroke or death, and there was a rate of 5% with CEA versus 11% with medical therapy. However, it's notable that there was a perioperative stroke and death rate of 2.3%.
Yeah, that's a really good point, because in ACAS, the way they proved that you actually had the degree of stenosis you said you did is they did cerebral angiograms on almost everybody. And there was about a 1% stroke risk from the cerebral angiogram alone. So, I mean, I think that's a real big red flag with that trial, but it has been what we've looked at the most.
Yeah. And then this trial was also performed in ACST-1 over in Europe. This went from 1993 to 2003. This was a large trial, enrolled over 3,000 patients, similar with an asymptomatic greater than 60%, with an endpoint of 5 years stroke or death. And it showed similar results with 6.4% stroke or death in CEA versus 11.8% for medical management. Most importantly, it showed that there was a durable benefit of CEA at 10 years, with a 10-year stroke risk of 13.4% in the CEA cohort. That was lower than the 17.9% in the medical management cohort. Notably also, there was a 3% perioperative risk of stroke or death in this study. Main limitations for this, these studies were at least 30, 40 years old at this point, and fewer than 40% of these patients received statins. It was not part of the clinical standard of care at this time. Much of the benefits that were demonstrated were mostly in men, since only 34% were women, and demonstrated no clear benefit in these patients.
Thanks, Andrew. I think that's a really good summary of the two major trials that looked at more historical, but carotid endarterectomy versus optical medical therapy. I think it's important that we also touch upon there's other trials, because carotid endarterectomy is not the only surgical option for asymptomatic carotid disease. Indeed, we have carotid artery stenting or transfemoral carotid artery stenting. And now, more recently, we have TCAR from that option. So let's go over the trials for carotid artery endarterectomy versus carotid artery stenting. So the tried and true trial that compared carotid endarterectomy versus carotid artery stenting was CREST-1. And later on, we're going to talk about CREST-2, but the CREST-1 trial was a randomized controlled trial, again, comparing carotid artery stenting to carotid endarterectomy in symptomatic and asymptomatic disease patients. The findings of this trial demonstrate that there was no significant difference in primary composite outcome. So that, again, that's a combination outcome of stroke, MI, periprocedural death, or periprocedural stroke. Indeed, however, they did find that the periprocedural stroke of carotid artery stenting was higher at 4.1% compared to 2.3% in the carotid endarterectomy group. However, the periprocedural MI rate was higher in the carotid endarterectomy trial, or carotid endarterectomy patient, at 2.3% versus 1.1%. Overall, I think CREST-1 is an important trial because it had 10-year follow-up that showed no significant difference in primary composite endpoint of carotid artery stenting or carotid endarterectomy. So in summary, you kind of have equivalent long-term benefits of carotid artery stenting and carotid endarterectomy for patients with asymptomatic disease, but you do have different periprocedural risk of either stroke or MI depending on the operation pursued.
Yeah, dude, I think that's a very important point to bring up, because that was probably one of the biggest criticisms when CREST-1 came out, that this combined composite endpoint of stroke, death, and MI was equal between the two, but in carotid endarterectomy patients, you had more MIs, and in carotid artery stenting patients, you had more stroke, and didn't sit right with a lot of people that you're doing a procedure to prevent stroke, and you had a higher risk of causing a stroke. And so I think that was one of the things that really made people feel like these composite endpoints didn't tell the whole story. And I think that's probably something we'll get into when we talk about CREST-2 too.
Yeah, very good point, Bobby. And I truly agree with that. And in my clinical practice, when I talk to patients, like on CREST-1, another important thing is the MI, periprocedural MI, they were looking for troponin elevations, which is a mild troponin elevation classified as a periprocedural MI compared to a full-on stroke, are different patient outcomes and how a patient experiences that outcome. So I think that was another one of the criticisms I remember heavily talking about when CREST-1 rolled out. And I think the other trial that's kind of come out most recently, looking at another operation to repair asymptomatic carotid artery disease, I think is important to highlight, is the Roadster 2 trial. And this trial was a prospective industry-sponsored, single-arm, multi-centered study specifically analyzing patients to undergo TCAR. This trial analyzed 166 patients who were deemed too high risk for carotid endarterectomy. 43% had what were deemed high-risk anatomical features, and that's typically considered either a high lesion, radiation, recurrent stenosis despite carotid endarterectomy before. And the Roadster 2 trial found 77% were asymptomatic with no strokes reported after the trial. And the Roadster 2 trial was really the trial that put TCAR, one of the more common operations now for asymptomatic disease, on the map. And I think that's important we address here today, because TCAR is a relatively common surgery that occurs in patients with asymptomatic disease.
Today's episode of the Behind the Knife podcast is brought to you by Gore Medical Products Division. The right dialysis access is a question that depends on each patient's age, anatomy, and medical history. The National Kidney Foundation's updated KDOQI guidelines recommend patient-first, individualized care that helps to preserve vessels for future access creation and avoid unnecessary procedures and complications. With Gore Dialysis Access Solutions, you can achieve and maintain reliable arteriovenous access quickly while adhering to the updated guidelines. See how at goremedical.com/dialysis. That's goremedical.com/dialysis. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
So, Frank, what do you think is the difference between carotid artery stenting and TCAR?
Yeah, like why does TCAR have a better outcome?
Yeah, no, great question. So I think when you think about carotid artery stenting, that's typically classically referred to as transfemoral carotid artery stenting, whereas TCAR, you access the carotid artery right above the clavicle. It's a higher level. So just for individuals on the podcast or on the call who haven't really done these procedures before, in transfemoral carotid artery stenting, typically you involve a distal embolic protection device that passes the area of significant stenosis in the carotid artery. As such, transfemoral carotid artery stenting typically has a higher peri-procedural stroke risk, and indeed that was shown in CREST-1 trial. However, TCAR is different. The fundamental technique of TCAR is different in terms of it involves reversal of flow. So you temporarily clamp the carotid artery, prevent antegrade flow up the carotid artery, and allow reversal of flow. As such, the stroke risk for TCAR is typically reported as less than transfemoral carotid artery stenting in that aspect. So technically the procedures, although both end result of placing a stent in the carotid artery, how you get there and how you go about doing the procedure are fundamentally different. Good question, Luciano. So, but now I think we get kind of the crux of this whole podcast, which I think is really important, not only for us, but the global vascular surgeons across the country, to talk about the CREST-2 trial, because that's the most recent trial that came out and really kind of throws some wrenches in the system about how we manage asymptomatic disease. So, Luciano, why don't you talk a little bit about CREST-2 in terms of its design and kind of what is the most recently found?
Yeah, so CREST-2 is what we all came here for. So the main question in CREST-2 was, does adding carotid endarterectomy versus carotid stenting to intensive modern medical therapy help prevent stroke more than medical therapy alone in asymptomatic high-grade stenosis? So the design was 2 independent parallel arms with their own medical therapy groups, which is that in itself is important. So they had carotid artery stenting plus medical therapy versus a medical therapy. That was one arm. And the second arm was carotid endarterectomy and medical therapy versus a medical therapy.
Yeah, that's a totally important point, because unlike CREST-1, they didn't compare endarterectomy to carotid artery stenting. This was endarterectomy versus medical therapy or stenting versus medical therapy, but not the 2 intervention arms against each other.
Right. And the patients in this study were high-grade asymptomatic carotid stenosis, so they had to have a greater than 70% stenosis, no disabling stroke, and had to all be eligible for either a carotid endarterectomy or carotid stenting, and all got the best their medical therapy. So some of the key findings for the study. So the stroke risk in the medical group was much lower than in past trials. So in this, it was about 1 to 1.5% per year versus the typically quoted 2 to 3% per year pre-statins. For the stenting trial arm, there was a 4-year incidence of primary composite outcome of perioperative stroke or death through 44 days or ipsilateral ischemic stroke thereafter was about 2.8% in the carotid stenting versus 6% in the optical medical therapy.
Yeah, that's another one of those good points. Sorry to keep chiming in, but this is like that composite outcome question that we talked about with CREST-1. So it's interesting, perioperative stroke or death through 44 days. I mean, how would you compare that to medical therapy? You know what I mean? Like You're just within 44 days, clearly you have a little bit more of a risk when you undergo a procedure that you're going to have something peri-procedurally. And so I think it's pretty impressive that carotid artery stenting still demonstrated significantly improved benefit when really it's getting penalized up front and then having to make it up on the back end, which was the remainder of the 4-year follow-up looking at the stroke risk. So it's one of those things you just got to really read into what these composite outcomes actually mean.
Right. Totally. Okay, so now for the endarterectomy group. The 4-year incidence of the primary composite outcome was 3.7% versus 5.3% in the optical medical therapy group, which was not statistically significant. It's important to note, though, that CREST-2 was not designed to test CEA versus carotid stenting, which we've mentioned, but optical medical therapy versus revascularization. And it showed that revascularization works. So revascularization works, but the absolute benefit is much smaller than 20 years ago. So with these findings, what were some of the limitations of this trial?
Yeah. So I think one thing that's important to remember here is that many of these limitations that are for this trial are just intrinsic to clinical trials in general. It's not perfect, and it's not possible to achieve that typically. But some of the limitations are OMT in the medical arms. It was to such a stringent degree that it's difficult and challenging to replicate in the real world, such as actually hitting an LDL of 70 in these patients. Secondly, was the number of cases that the interventionalist had to submit, in that the interventionalist had to do 100 transfemoral carotid artery stenting with at least 25 cases performed in the past year, with only 50% of applicants accepted. Surgeons on the CEA arm, however, had to submit only 50, so half the number of op notes, and this was over any time period with a 90% acceptance rate.
Yeah, it's super important to know because, Frank, I don't want to speak for you, but I think CREST-2 really bumped down, or CREST-1, really bumped down the number of carotid artery stents that I did. Mm-hmm. And so I'd say performing this many within the past year would be hard for most practitioners. You'd have to be really cranking them out to be able to get this many on there. So that's a real limitation. You have to ask yourself, are you the type of person performing the studies or the interventions in this study? And do your outcomes for when you do it replicate what they saw here before you can interpret whether or not you can compare that to medical therapy in your patients?
Yeah, I 100% agree. Transfemoral carotid artery stenting after CREST-1 did semi-drop in practice, and the number of people across the country perform this number of procedures for transfemoral carotid artery stenting is limited, and when they do a lot, they develop a technical expertise at it. So it can't be globally applied to all practitioners within the country.
Yeah. So another component here is just a degree of disease that were able to be treated. So stented lesions needed to be less than 2 centimeters long. Circumferential calcification was ruled out for these patients, and they could not have any unfavorable anatomy or disease in the inflow vessels, which was determined by the operator, such as a type 3 aortic arch. Another limitation here was the 2 separate medical arms. Overall, the incidence rate of stroke were different between the 2 arms, such as a 6% risk of stroke and death in the transfemoral carotid artery stenting arm at 4 years versus 5.2% in the surgical arm.
Yeah, some people have wondered if that made it underpowered to be able to detect a difference in endarterectomy because, they didn't see a difference in endarterectomy versus optical medical therapy significantly, but percentage-wise, it was a pretty decent difference. And, I know there's liars, damn liars, and statisticians, but at the end of the day, you wonder if the power is really what made carotid endarterectomy not have as favorable of a look as carotid artery stenting did.
I'm sure we're looking forward to all the subsequent follow-up studies there to follow with this data.
Yeah, good. It's a gold mine.
Yeah. So next up is there was a greater than 20% crossover between the medical and intervention groups with each arm, so with the intention to treat analysis that they had. This is intrinsic to many clinical trials. An important thing here is the follow-up timeframes. They were different between carotid artery stenting as well as a CEA cohort. That the CEAs had additional year of follow-up versus the transfemoral carotid artery stenting, given that there was suspended recruitment for a period in time for the carotid stenting. And importantly, in the CEA cohort, in the final year of follow-up, there was a high incidence of follow-up events, which resulted in the inferior outcomes. Whether or not this would have happened with carotid artery stenting is unclear, but they had a shorter period in follow-up there. And finally, this study didn't include TCAR, which is a very common procedure now as the modality for stenting for these patients, especially when you take into account the learning curve that's involved with TCAR compared to transfemoral carotid artery stenting. There are numerous studies out there evaluating how do physicians handle that learning curve and how many cases does it take. With transfemoral carotid artery stenting, it's typically 50 to 100 cases. With TCAR, it can be lower, as low as 30 cases or so. And given that, there are concerns, as we discussed previously, that perhaps less experienced practitioners who really aren't hitting the numbers to meet CREST-2 inclusion, like we discussed earlier, might be attempting carotid artery stenting and not be having the favorable outcomes that were demonstrated in this trial.
Yeah, I mean, for me, that kind of pushes it to be even a little bit more impressive. I mean, because TCAR has a lower stroke incidence than most trials that have looked at transfemoral carotid artery stenting. Now, they haven't been compared directly, but when you look at Roadster results, it's, between 1% and 2%, what we would traditionally actually quote for endarterectomy. That being said, TCAR wasn't included, but still carotid artery stenting did better. So that learning curve that you're talking about probably played into why carotid artery stenting looked so good here. I do wonder, though, if you had included TCAR, would it have looked even better?
Mm-hmm. Great point.
Yeah. So talking about some of the clinical significance of the trial, right? So this is the first trial that shows that carotid stenting plus intensive medical management beats medical management alone in asymptomatic patients. The decision is individualized, though, right? So you have to take into account the patient age, their surgical risk, their life expectancy, the plaque morphology, and the patient preference. But sort of based on the limitations of this trial, it's difficult to incorporate these findings into the clinical practice. So Bobby and Frank, say that we have a patient who comes into your clinic with high-grade asymptomatic carotid stenosis. Can you walk us through first how you just work that up and what you would offer this patient?
Yeah, so I think it's, as you mentioned before, for the decision is really individualized, right? So you have to consider the patient, their risk factors. Are they advanced age, not going to meet that 5-year life expectancy that you'd expect for asymptomatic carotid disease? Do they have a number of other cardiovascular comorbidities that would prevent them from reaching the long-term benefit of a surgical operation? First and foremost, for all patients who walk into my clinic, I think this trial, CREST-2, has shown that they need to be on optimal medical therapy, and that's, as Bobby already pointed out with a great discussion of medical therapies, you need to optimize their statins, their antiplatelet therapy, their glucose levels, their hypertension, and their smoking cessation. So that needs to be first and foremost, because that has been shown to significantly decrease the risk of stroke, even compared to 20 years ago. For patients who are optimized and do have a relatively long life expectancy, when you talk about asymptomatic high-grade carotid stenosis, I consider an operative intervention for carotid endarterectomy or carotid artery stenting. However, prior to doing that, I typically get a CTA of their head and neck to evaluate the plaque morphology in the carotid artery. So is it a highly calcified plaque? Is it a ulcerated plaque? How high is the lesion? Those aspects, because that typically would push me one way or another for a carotid endarterectomy versus a TCAR is typically my practice for a carotid artery stenting. So that's kind of how I work up a patient and talk counsel them in that way.
Yeah, I think that's important to mention too, because in CREST-2, this trial that we've been talking about, they didn't do anything beyond plaque degree of stenosis. There was no morphology characteristics. And a lot of us will look at whether or not it looks like an ulcerated plaque by duplex ultrasound or by CT. We'll look at some of the plaque anatomic characteristics to say whether or not this patient should get intervened on. So I totally think that's a very smart point that you end up having to bring up, that most of these patients will get a confirmatory study with a CT scan.
Yeah.
I think the, overall thing is, there's a little bit of like a Rorschach type thing before. People were looking at whatever when they saw the old trials, and they were saying, well, I don't know if I want to intervene as much. And those who are more comfortable with medical therapy or couldn't do surgical intervention, they felt like the trials didn't apply because we have all these new modern medical interventions like the PCSK9s, the GLPs, statins. I mean, doesn't even seem that new, but statins. And what I think people were hoping for, though, is with this trial, we would get a much more definitive answer. And dare say that some people were hoping there would be a non-inferiority because it would prove that the medical therapy had really advanced. When I look at this, I tell people you're amongst one of the most studied group of patients that we have right now, because this is such a gray area problem. It's incredibly critical, like Frank mentioned, that you're on medical therapy, because just the advances in medical therapy alone have lowered this stroke risk. I mean, I had a patient in clinic recently who's 80, still working. I don't know what that says about our social safety net programs, but 80 and still working, and said, wait, so my stroke risk at 4 years is 6% with medical management therapy, or if you do a carotid artery stent, it's a little bit less than 3%. And if you do a carotid endarterectomy, it's a little bit over 3%. He said, 6% doesn't sound that high to me if all I have to do is take some medications. Whereas in the past, our conversation with that patient would have had to been, hey, your stroke risk is 10%, or, as you talked about the 10-year follow-up data for ACAS up to 17.9%. So, I really do think that this is, if you need to have your patients on medical therapy. And then I'd say it doesn't answer the question about TCAR at all. I'm still doing TCAR in patients, and I tend to look at this as maybe just underpowered or some of those limitations driving the non-inferiority in the CEA group. And I tend to say for most of my high-grade asymptomatic patients who are on medical therapy, have maximized lifestyle changes, and have a life expectancy that exceeds 3 to 5 years, that, yeah, we should really consider an intervention. And we lay out the numbers, and if it makes sense to them, it makes sense to me.
What about a patient, let's say 92 years old, but they have the eye of the tiger, they play golf every day, and they otherwise have no other medical conditions?
Yeah. I think what you're getting at is, these are a little bit older patients. We don't do a great job at looking at actuarial data to say what your survival is going to be. And so I think what you do have to do is treat that patient that's right in front of you. If they're a functionally active patient, then I tend to get a little bit more aggressive about intervening for them, provided that they understand what we're talking about here, because you do buy some of the risk up front when you do an intervention. It's like we talked about with the CREST-2 results, where that 44-day peri-procedural stroke risk and death risk was one of the metrics. And so you are doing something to them that can cause an issue. And some people have a really big problem with the feeling like they did something that then caused them an issue. And some people are like, hey, it's going to be what it's going to be at 92.
Yeah, and I think as much as there's a quote unquote healthy 92-year-old, one of my former mentors said a surgeon or patients always show their age under surgery. So like even the healthiest 92-year-old is still 92, right?
Yeah.
So you just have to be cognizant of optimizing their medical therapy, making sure they understand the risks. And like you talked about your patient before, the 80-year-old who said, wait, 6% is not that bad when I'm 80 or when I'm 92, and they might choose that, and that's fine. But you have to optimize their understanding of what each condition offers though.
All right. It's been a great discussion. Thank you, Frank, Bobby, Luch, for participating today and discussing asymptomatic carotid management. And as always, dominate the CEA.
What? Dude, dominate the day.
And go blue.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.